I stop? Pause. Okay. All right, we will start. Good evening. My name is Dr. Venu Verghese. I have a company. I teach doctors to pass the AMC exam, part 1 and part 2. So the first thing, the reason I'm running this session is because the pass rate for the AMC OSCE is a little low, and it makes you wonder why it is low. And I feel that if you understand what an OSCE is all about, it will make it easier. So the first question is, so we know OSCE stands for Objective Structured Clinical Examination. So the first question I have for you is that what do you think OSCE is really? Why do we have OSCE? Does anyone know why we actually have an OSCE examination? If you may have studied in different universities, and have you ever sat for an OSCE exam before you came to Australia or before you had AMC exam? Unlikely, right? So the reason why we have standardized medical test IMGs for the level. Yeah. Okay, so the OSCE is a standardized examination. Why we need standardized examination? So I grew up, I was born and raised in Malaysia. So our exams, we call it the long case and the short case. So assume that you have a patient who did not like blue color. And on that day, on your exam day, you wore a blue color shirt, and the patient decided that patient is not going to cooperate with you. And the patient is not going to tell you any of the symptoms because you wore a blue color shirt. So then you're passing that station, the chance of you passing that station is going to be limited because patient was not responding to your questions. So there is a need to fix that. So if you can standardize the room, standardize the patient, standardize their symptoms, so there is less chance of an error. So then we are only testing you, what you do on that 8 minutes. So that is why, so the OSCE exams are pretty reliable. I know if you have given the exam and if you actually fail the exam, it is devastating and you would be very angry and upset that the system is wrong. But actually the system works. It is, I am all for an OSCE examination because it actually works. It'll actually test your skill. So I write OSCE stations, and when I'm writing an OSCE station, I decide what are the domains I want to test. And those domains can actually be validated statistically when we review that station afterwards. So I'm not an OSCE examiner for AMC, I'm an OSCE examiner for universities. But OSCE works, it actually tests. So let's go through the slides. So the first thing first, I acknowledge the traditional owners of the land on which we meet, pay my respects to elders past, present, and emerging. This is an educational purpose only, doesn't replace professional or medical advice or clinical judgment. So my name is Dr. Verghese. I introduced myself earlier. So I'm glad you're here because I want to talk about OSCE. So I said I write OSCE cases and we test them. So every time an OSCE station is created, so the things that we are looking for are your clinical reasoning, that's the most important thing, your communication, your competency, and your consistency, how consistent you are. So what is the difference between a clinical reasoning and a clinical knowledge? So most of the time, doctors sit down and they read all the mutkags and the handbooks and they learn. That is your clinical knowledge. That is not your clinical reasoning. The clinical reasoning is that you have a pregnant woman with you coming to the clinic, and her BP is sitting at 135/90. And your clinical reasoning at that moment is, what am I going to do with her? What are my priorities? What are my differential diagnoses? Your clinical knowledge is everything about eclampsia, preeclampsia, HELLP syndrome, all of those. AMC does not test your clinical knowledge, it tests your clinical reasoning. And that is really important. I've seen a lot of people who say that, oh, I'm going to study the next 6 months and prepare for this exam, and then I book the exam and sit for it. That is not what you want. What you want is a few months, maybe 8, 9 weeks, where you actually practice the OSCE. You sit with someone and practice continuously. You must practice on at least about 150 cases for you to be able to pass the exam. You need to practice constantly. So that is the number one reason people fail, because they fail to distinguish the difference between a clinical reasoning and clinical knowledge. The second thing is your communication. So often after the exam, we tend to talk to other people, and when someone passed, we ask them for their past feedback. But what you don't understand is that when you walk into the OSCE room, you're marked from the time you enter the room to the time you leave the room. Every single thing that you do is counted. The way you look, not the way you appear, but the way you look, the contact, the eye contact that you have to the patient, the way you sit, the way you listen to the patient, the way you cut the patient when the patient has some concern and you don't acknowledge it, those things actually matter. So that is your communication skill. So to be a good doctor, you must be able to communicate properly. And that is actually graded in an OSCE, not just an AMC OSCE, but in any OSCE, that is one of the key skills. The next thing is competence. So sometimes the STEM tells you something, and then you actually have to do something else. I'll come to that question in a little while later, but that is where your competence comes, because it is testing to see whether you understood there is something dangerous happening here and we need to act right away, even though they're asking you to do a test or something else, but you need to be competent enough to understand when an emergency situation presents in front of you. You do that, you pass. Consistency. So every station expects a certain consistency from you, how you walk in. So when I gave the AMC exam, I actually stood in front of the mirror and I practiced saying, hi, my name is Dr. Verghese. I'm here to do a cardiovascular system examination. I said that continuously. I probably practiced this 100 to 200 times, just that one sentence, because it needs to come fluent from my mouth. I don't want to stumble. I don't want to look lost. So it's important that you actually say it correctly. Practice what you're going to say. Standing in front of the mirror actually helps. So this is the common things that an OSCE tests. Any question here? All right, we move on to the next one. So the common mistakes most of the international medical graduates make is that you have a checklist. So you follow a certain notes, a magic formula, whatever notes that you follow, you have this checklist in your head and you try to follow it. Whereas an OSCE is a very fluid, evolving station. If your actions don't match the station, you will fail. Second thing is that you don't see the patient's main concern. The patient is trying to tell something to you. Neither the patient nor the examiner wants you to fail the station. They're all there to get you across. They have cues. They're trying to tell you something. You don't listen, you don't acknowledge it, then there's a problem. So, and then your structure. The structure is probably one of the most important thing in an OSCE. So remember, it's an objective, structured clinical examination. So the structure part of it, how you do things. I was an examiner for a year two OSCE recently, and my station was an X-ray station. So I teach X-ray at the university for med students, how to read the X-ray and ECGs. So on that day of the exam, so we had 39 students, and there was one student walked in, and he sat down, he sat very properly, and then he read the X-ray so beautifully. I was mesmerized. And then at the end of it, he even asked me, do you have a ruler to do the cardiothoracic ratio? Because before the station started, I was asked to hide the ruler. I can only give the ruler if the student asks. Of the 39 students that day, he was the only one who asked. He had the structure. He knew that every X-ray, chest X-ray, you actually have to measure the cardiothoracic ratio. I had to frantically mark his performance in the 2 minutes after the OSCE because I forgot to mark. Then on the same day, I had another doctor walk in, medical student walk in, and she was so chaotic. And I thought, oh my goodness, what is wrong here? And I taught these two doctors, so I know I did my job well, but she didn't study. So we understand every OSCE examiner knows your structure. The more you stumble, the less practice you are. Don't stumble, practice. Make sure there are only so many OSCE stations in the world. You should know them all, and you should be able to pass. Forgetting empathy. So when you're so focused on your checklist and the thought that, oh, I must pass this station, I paid a lot of money. And also, one of the common mistakes for people is that when you start role playing, the first few weeks, where you remember all the empathies and all of that, but then you get into a pattern and you try to get your own, because I already know how to do the empathy, and you miss all of those. And then come exam, that same thing continues. So always make sure that you check constantly that you haven't lost your empathy. You're still practicing with the empathy. So forgetting the empathy is probably a big problem. Poor closure. So what does mean closure? So every time I finish an OSCE station, when I was giving the AMC exam, I always asked the patient, do you have any questions for me? Are you okay? That was really important for me as a doctor, making sure that I've had a closure. And that worked. And the last thing is ignoring patients' cues. Sometimes they are trying to help you pass. You need to see the cues. When they talk to you or they have some actions, look at them. So this is a structure I followed and it worked for me. So introduction, every single station. So the examiner usually introduce you to, this is happening now. When we gave the exam, it wasn't there, but now apparently they introduce you to the patient and say this and start the station. But I practiced that, hi, my name is Dr. Verghese. I'm here. Whatever the case was, I'm here to do that, and then continued with it. So introduction is really important because that few seconds matter. Your examiner is observing you, the patient is observing you. You are the star of that moment. Get your lines right, you do it well. The history. So one of the things I've always noticed, especially in a pediatric history, is that a lot of people come. So assume a 7-year-old child with a limping problem. So they ask, okay, when did it start? What did it start? How did it start? And then the next question is, what about the birth history? So think, a 7-year-old child, how relevant is the birth history? Is it a vaginal birth? Was there any other drama? 7-year-old child, birth history is not that relevant. The only thing in that birth history that you want is, was the child diagnosed with developmental dysplasia, because you have 20% chance of getting um, either SCOFY or even the Perthes. But that apart from that, you don't need the birth history, but you do it because in your station, when you practice, you follow BINDS, birth history, immunization, nutrition, whatever, I don't even, development. You practice that, but then you forget a 7-year-old or a 10-year-old child does not require birth history. It's not birth history focused. You need to take the presenting history. So every single station, you need to develop that skill to understand what questions you must ask. Physical examination, you either have to ask the examiner physical examination, or if you are giving the online exam, they will give you that finding. You need to know the management. It's really important that AMC is now looking at a lot of management is coming up. So please learn management and the closure. Here, I always get through the ideas, concerns, and expectations. This was something as a tutor, I actually hated teaching that, but I see the benefit of the ideas, concerns, and expectation, and is commonly used in every single system, so you need to know it. So how to practice empathy? Because empathy is one of the most important skills you need to develop for you to pass the exam. So you build a rapport early. Whenever the patient is looking at you, smile, show them you really care, and develop that rapport, and they will be with you. Second thing is to acknowledge the emotions. Everybody says, I'm sorry. Are you really sorry? You're not. So you could say that better. I can see that you're worried. Or I can see that you're concerned. Let's work together. Let's figure out what's going on. That is the acknowledgement of the emotions. Maintain an eye contact. You must maintain eye contact. They will mark you down if you don't. And use the layman terms. So every explanation that I wanted to do, I actually practiced. I've recorded myself and then I heard it myself to see whether I would be happy if someone explained to me like that. And that actually worked for me. So if you worked in Australia, you would see that a lot of Australian doctors follow this method. So we teach our med students to do this. It's solar. So sit squarely, open posture. You lean forward slightly, as I'm doing now, and then eye contact and relax. So if you do this in every station that you can sit down, that would work for you. Second thing you got to do is that there is a paper for you to write. Please use it. One, it's a good practice writing things down because you don't want to forget your patient's name. You don't want to forget certain things that they've said. So you need to write things down. Second thing is that the examiner will have to throw that paper as you leave the room because every time the room has to be kept exactly same for all doctors. So examiner will also see what you have written. A good doctor writes. You want to impress the examiner? Right. So you need to practice with someone that can give you a better feedback. It doesn't matter who it is, but you must practice with someone. So the aim for anyone who sits for an AMC exam is that you must practice minimum 150 cases. So if you come to my university, you would see every single med student, they have a target of 150 cases. They would practice 150 cases before they OSCE. The same thing for you. You need to practice 150 OSCE. That'll give you the hang of how to deal with it. So self-practice, if you read and practice yourself, it's not going to work. You need to practice with someone who gives you feedback. You need to do mock exams because mock exams actually show you where you are standing. It's so important to do it. So I have a case. Would anyone like to do the case with me?
I can do
If
one.
you do, okay, go ahead. All right, so the case is here. Let's go. I can put the timer up. Ready when you are.
Sorry, the task is just physical exam and outline initial management.
Correct. When the clock is 8, you got to start.
Alrighty.
They have 20 seconds left.
Okay.
Okay.
Hi,
Start.
Arnold. My name is Yel. I'm one of the doctors here Is it just Arnold, or do you want to be called something else?
No, Armstrong's fine.
All right. So I can see here on my notes that you have some chest pain, and I'm sorry to hear that. Can you please tell me more about it?
What would you like to know?
Right. So just gonna go through some details with you. You've had chest pain for the past 2 hours, and
Correct?
it's getting worse.
Correct?
Right. Can you point to me where you have the chest pain?
Oh, it's all over. It's from my tummy is going all the way up.
All right. That must be concerning. Can you tell me more about it?
What would you like to know, doctor?
So I can see you're in a bit of grief right now.
Mhm.
Um, is the pain going anywhere else?
Yeah, it's going to the back. It hurts.
Hmm. And how would you describe the pain, Arnold?
Bad.
So I can see here it's a sharp kind of pain.
Mhm.
And from a grade of 1 to 10, 10 being the worst, can you rate your pain for me?
15.
15. So sorry to hear that. Um, can I offer you any painkiller at all? I can see you're very much in
They
pain
have
right
given me
now.
they have given me medication. I'm waiting for it to work.
Excellent. Um, do you have any other associated symptoms such as shortness of breath, palpitations?
No.
No. Okay, so Arnold, I'm just gonna ask you a few more questions just to rule out anything. Oh, sorry. The task is to do a physical exam.
Mm-hmm.
I'm so sorry. So thank you for all that information, Arnold. I'm just gonna do a physical examination on you. Is that all right?
Mm-hmm.
Okay, so I have your vitals here with me. I'm gonna perform mostly a cardiovascular examination.
Mm-hmm.
So on um, so I can see on inspection that the patient is in pain,
Mm-hmm.
and I'm looking for any cardiorespiratory distress, and he is able to speak in full sentences.
Okay.
Um, I noted that he is tachycardic, tachypneic, and his saturation is low.
Okay.
Um, for the cardiovascular exam, I'm starting with the neck. On inspection, I cannot see any raised JVP.
Mm-hmm.
Um, and then I'm going to move to inspection of the chest. Do I don't see any surgical scars indicative of a cabbage. Um, I do not see the apex beat being displaced.
Mm-hmm.
Then I'm going to move on to palpation using the
Mm-hmm.
fingertips to check for any palpable thrills on the aortic, pulmonary, mitral, and tricuspid valve locations. And I don't feel any. I'm going to use my ulnar edge of my hand to feel for the palpable, for any heaves which are not present. Then I'm gonna move on to auscultation using initially the bell of my stethoscope on the mitral valve, then switching to the diaphragm, hearing for any murmurs. So heart sounds are dual, no murmurs on the mitral valve. Moving up to the tricuspid, pulmonary, and aortic. Um, and then I'm gonna qu- um quickly check the legs for any swelling or edema, which are not present. Um, and then I'm gonna perform a respiratory exam as well. Initially on inspection, I want to see if there's any use of accessory muscles, such as the sternocleidomastoid or the um, shoulder and pectoral muscles for any increased work of breathing, which are not present. Then I'm gonna check the neck for any tracheal tug or any deviation. Then I'm going to perform an inspection of the expansion of the chest. So I'm going to go on top of the patient, look at the upper lobes, then go to the back, then look at the posterior lobes of the lungs, and I can see that there's symmetric chest expansion. Then I'm gonna move on to palpation using my fingers. I'm gonna put them on the posterior chest of the patient and ask him to breathe regularly. I'm gonna put my thumbs in the midline and see if there's any decrease in thoracic movement, which is none. Then I'm gonna do percussion on the intercostal spaces, looking for any dullness, which is not present. And then I'm gonna finally do an auscultation, starting with the bell for the apices bilaterally, then moving on to the diaphragm for the different auscultation points in the lung. And then I'm gonna request for an office test. So this patient has a background of COPD. I can request for a spirometry. I can hook the patient to the 12-lead ECG. Yeah, so that's my physical examination.
Okay, you have 1 minute and 40 seconds left. All right, I'll pause the time. Would anyone like else? So, first of all, Doctor, thank you for doing this. You're brave enough to do this because I just threw it out at you and you took it. Thank you. And I will give my comments in a few seconds. Anybody else would like to have a go at it?
Look, do you want us to add something?
You tell me. How would you approach?
So here the presenting complaint is abdominal pain.
Mm-hmm.
And so like what I thought was the patient is having abdominal pain and the vitals are like the patient is having hemodynamic instability as well. So firstly, I will tell about the stabilization of the hemodynamics. Then I'll offer a painkiller if he is in. I'll ask the pain scale.
Mm-hmm.
Offer a painkiller. Then I would like to start with, but here they gave physical exam. So firstly, I will perform an abdominal examination and I'll also go for respiratory and cardiovascular afterwards,
Mm-hmm.
as the patient is having the background of MI and COPD, but my main focus will be on the abdominal examination.
Mm-hmm. Don't worry, doctor. I know we all make mistakes. It's not the end of the world. Learning from the mistake is really important. Okay. Anybody else would like to have a go? Making mistakes is actually good because you learn from it.
So doctor, can I do that?
Hmm?
Can I do the examination like how we do in the exam?
Yeah, you tell me. I'm waiting.
Okay. Sorry. So hi,
Hold on. Let me give you the timer.
Okay.
All right, you get 8 minutes. Go.
Hi Arnold, I'm Dr. Anusha and I'm one of the doctors here. So I can see that you're in pain right now on his.
Yeah. Very painful.
Huh?
Very painful. I mean, so much pain.
Yeah, I'm really sorry to hear that. So on a scale of 1 to 10, how bad is your pain?
15.
So would you like to have a painkiller at the moment?
They've already given me.
Okay, so it will take some time to act. So meanwhile, I want to stabilize you. So examiner, I want to shift the patient to the resuscitation room and connect to the monitor and then start with the resuscitation. Meanwhile, I'll do the physical examination on the patient.
Okay.
So Arnold, I'm going to check your tummy, heart, and also your lungs. For this examination, you have to be in a lying position, okay, and you have to bring your legs towards your tummy, and you have to expose all your tummy. And whenever I need the chest examination, I'll also ask you to expose that chest as well. Okay, is that all right? And if you have, yeah, can you tell me exactly where is your site of the pain in your tummy?
Whole tummy is painful.
All over the tummy. Okay. Okay, examiner, now I'd like to start with the inspection of the abdomen. So on inspection, I'm looking for the raise of the abdomen with the respiration. And I'm looking for any scars, swellings, or any visible masses. And I cannot see that, or if present, I'll comment on that. And then I'll start with the palpation. So the superficial palpation, so firstly, I would like to start. Right now, I don't know like where he's telling diffuse pain. So I'll start with right upper quadrant. So I'll go in all the 9 quadrants. I'm palpating from the right quadrant to I'm going to the left lower quadrant. and then I will do the deep palpation as well. Examiner, I did the superficial palpation for any tenderness or any rebound tenderness, and now I would like to do the deep palpation for any rigidity or guarding tenderness as well, and for any masses with palpable masses. Then I would like to do the percussion. So I would like to do the percussion again. I'm doing on the all 9 quadrants percussion. I'm looking for any dullness or resonance. Then I would like to do the auscultation. So I'm looking for any auscultation of the vowel sounds for a hyperactive vowel sounds or absent or present vowel sounds. I'll check below the umbilicus. Along with that, I would like to do kidney in the Murphy sign to check for any to rule out cholecystitis on the right upper quadrant. So I will ask the patient to breathe in. Then I'll place my hand on the right upper quadrant. I'll ask him to breathe out, exhale. Arnold, can you please exhale? Then if he's having pain, then I have when I'm palpating, he'll have pain. Then I have to take it out. So that is Murphy signs positive, if at all, if the patient is having pain. Then if he's having depending, then I will also do the kidney ballotment. But here there is no need of kidney ballotment, right? Yeah. So kidney ballotment is not necessary here. So I'll do the Murphy sign. And for appendicitis or to rule out appendicitis, I would like to do a Rosing and also a Rosing sign. So I would like to press on the opposite side to check for tenderness on the left lower quadrant. So that is Rosing sign. And if needed, if he says pain, then I will go for psoas and obturator. Now I would like to proceed for the chest examination. So examiner, I would like to quickly inspect and auscultate the chest. So on inspection, I cannot see any scars, swellings on the chest, and I cannot see on the axilla. And then I would like to do the palpation. I would like to proceed to the auscultation. So on mitral valve, I'm looking for any, I'm doing auscultating with bell and looking for S1, S2 normal and no added murmurs or sounds. Now I'm changing to the diaphragm. S1 is to normal and no added sounds or murmurs. So I'll ask for next, I'll check on the tricuspid. S1 is to normal, no added sounds or murmurs. Now I'm checking on the pulmonic. S1 is to normal, no added sounds or murmurs. On aortic, S1 is to normal, no added sounds or murmurs. So there are no added sounds or murmurs. So now I would like to proceed with the respiratory. So on inspection, I can see the patient is using the intercostal muscles for breathing, and the saturation is also low. Now I would like to start with the auscultation. So I'll start with the supraclavicular on both sides with bell. Now I'm checking the diaphragm, like on all like anterior. Please, Arnold, can you take breathe in and breathe out? Breathe in and breathe out. Breathe in and breathe out. Now I'm checking on the axilla. Then I'll go to the posterior side. And yeah, so usually they'll give 6 minutes. So I thought maybe.
Okay. Done?
Yes, doctor.
So you have 1 minute and 54 seconds to spare. That's okay. Anybody else want to do better, or anyone else want to add anything else? There are how many of you? There are 22 of you. Be brave. The only way you learn is by making mistakes, and it's okay to make mistakes. Anyone? Anything to say at all? Go
Doctor,
ahead.
if time is there, maybe I would like to check bruise also. Aortic bruise, because patient can have abdominal aortic aneurysm. Yeah, so maybe.
Okay. Anyone? Anything else to say? All right. So this is one of our classic OSCE cases for my med students, and I'll show you how we approach. Okay, so one of the this is my method. I usually tell people to follow something called the pulse method. So you prepare. So you read the station very carefully. So when you stand in front of the door, sometimes you see that the stem is very long. So every time we write an OSCE station, for my university at least, I read the station first. Then I get my friends to read the station first. And then we get the students to read. So, if you're writing year 4, we get the year 3 students to read. So the idea is that you must be able to read this complete stem in 2 minutes, 2 times. You should be able to read it 2 times in 2 minutes. You panic when you see a long stem, panic, don't have to. You have time. And even if you didn't get to read all of it, the stem is also inside the room. All right? So you need to prepare. Read the stem carefully. Next is understand. So understand what is the concern here. Third one is lead. So you need to take control of the situation. And the S is to summarize and solve. And E is how you're going to end this or educate, whatever that task is. So if you go back to the previous slide, the prepare, you read the station. And the next one is understand. So what is the problem here? So my problem is that my patient is actually crashing. That BP is 92/76. I need to start fluid resusc now. This patient will die in the next 1 minute or 2 minutes max if I don't do anything. But they put that in very subtly because you only read the perform a physical examination. You did not see, or you saw the BP, but you still followed that perform a physical examination part because that is what was said in the stem. Remember, exam is looking to see if you're competent or not. And this is how people fail the exam. So how do we manage this? This is how we do it. This particular station, this is how you do it. So we're going to follow ABC. You're going to call for help because this patient is crashing. You want to give the patient oxygen now. We need to give the 2 large bore cannulas in, start the blood. So send for all of them. You need to tell the examiner, I'm going to get the blood group and match and hold. We are going to run the ECG quickly, order for the X-ray. We're going to do the IDC. We have to have the arterial line in. Admit, analgesic, nil by mouth, antibiotic. So I'm going to order the broad spectrum. Give me a second. Core vascular referral, anesthetic, ICU, consult urgent laparotomy. Yes, doctor, go ahead. What was your question?
Yeah, so doctor, whenever we have that hemodynamic instability, we can just mention about all this management, right?
Yes, you
So
will
there is
mention.
no hard and fast rule that you shouldn't mention. Or
No, you must mention.
must mention. Okay.
You are the doctor.
Yeah.
Imagine it to be your real life patient.
Yeah.
Because you need to, why did you become a doctor? To save lives, right?
Yes. Yes.
So when someone is going to die, it's your job to step in and do it.
So we
So
can't
the
just
go ahead.
generally
Sorry.
tell that we are stabilizing the patient, we want to stabilize and all. We have to clearly mention what we are going to do.
Yes.
Okay. Okay.
So then you pass. We
Yeah.
showed them that you're a safe doctor.
Yes. Okay.
When you stabilize, you're just like everybody else doing something randomly without knowing why it's important,
Yeah.
right?
Yes. Yes.
But the important thing here is that my patient's BP is 92. I need to start the fluid resusc.
Hmm.
I really need to get the bloods done because we will be initiating the massive blood transfusion protocol in the next 10 minutes.
Yes.
If I have to initiate that, I have to have everything ready,
Hmm.
right?
Yes, doctor.
My job is to save lives. My job is to show my boss that I am a safe doctor. After you do all of that, you can do the task was physical examination. So you still have to do the physical examination. All you want to do is to tell, I'm going to do a quick general inspection. Well, unwell, conscious, unconscious, whatever. What is the grade of the patient's pain? Positioning, I really would like to say, is he lying motionless? I want to know his hydration status quickly. I really will acknowledge his shock status. Is the peripheries warm, cold? Is there pallor? Is he tachycardic? And the vitals we are continuously monitoring now. In the abdomen, I'm only interested in if there's any scars because I want to know if there's any previous surgery. Is there any pulsatile mass? Because this is most likely a AAA. Is there a distinction? Asymmetrical movement of breathing. peristalsis that I can see. I can ask the patient to cough just quickly to see a hernia. Her patient, I want to know if there's a peritonitis, bone-like rigidity, a generalized tenderness. Yes, sorry. Generalized tenderness, guarding, rebound tenderness, percussion tenderness. And then we want to know if they're auscultate. I'm looking for bowel sound, absent bowel sound, or high pitched bowel sound. Is there a bruit for the AAA? So you were right. Yes, you have to do the bruit. Then we want to know, is there any special, so the special test and signs that I would tell the examiner is that I would do for the appendicitis, so as obturator and Rovsing sign. For pancreatitis, I'm going to do Cray-Turner's and Cullen. And acute cholecystitis Murphy's, AAA is going to be if there is any distal embolization or thrombosis, and I'm going to order about bedside ultrasound. I will order a CT contrast if there is a need to. I will ask the boss if I need to do a CT contrast. This is it. But you see how easy to fall into the trap because we follow only what is said in the station? So if you don't read where exactly is the pain, is it the abdominal pain or chest pain, we lose the whole station because it's important. And this is how we make mistakes. And the next thing we need to know is that is it emergency or is it normal? Because the station will tell you this is very simple. So it's an extremely simple station, and most people fail because they don't see that BP. A couple of you actually noticed it, but didn't do anything about it. You said you moved the patient to the rhesus room, but didn't do much. So this is the reason people don't pass the AMC OSCE. And not just AMC, generally an OSCE examination. So you asked about resources. So if you have somebody who has RSCGP account, you should be able to download this book. I highly recommend this book. I personally have never read the AMC handbook and I will never read it because I have OCD and I need to have things in a certain order. That book will drive me insane. So I passed AMC exam. I got 12 out of 14 stations. I've never read the AMC handbook. I also have never read Muttag. As you can see behind me, I have 2 copies of Muttag. My auntie is a general practitioner, so I have her copy. My sister is a GP, I have her book. So I have 2 Muttags, I've never read them. So this is the only book that I read, and this is the only book that I like. So it's available in Amazon. So if you go to this drive, this is done by a student of mine, a med student of mine. He was an electrical engineer, and he decided that engineering is not something he wants to do. So after working as an engineer for 7 years, he decided to do medicine. He wrote GAMSAT exam and started doing medicine. And so he looks at things differently compared to most doctors. So he created 2 Google Drive. You should be able to find it online. So one is his mnemonics list. I really love it. And then this is his approach to OSCE. Quite a lot of cases in there. Give me a second. All of the physical examination videos are from Geeky Medics. So Australian medical students follow Geeky Medics for physical examination, and I'm sure your examiners will be happy if you follow the same thing. I personally like Life in the Fast Lane. I don't know if you heard of it. So there are a lot of resources. It's started by an ED doctor in Australia, and it's got a lot of good resources. They actually have a video about interviewing a patient with the query non-accidental injury of their child. So there are podcasts I listen to. One of his is the Unofficial Guide to Medicine podcast. Recommended highly. A Journey Through Medicine is another one that I listen. And then this is another one. And there's an OSCE revision playlist on Spotify. These are the resources I use. So I have 2 courses. I just wrote the comparison. I have never ever given a group classes, but I've had a lot of people ask me because if I can run group classes, making it cheaper because I actually charge $100 an hour for my one-to-one OSCE coaching. So I've started this, and which is a 12 weeks, so it starts on the 15th of November. It's only 5 doctors in a group. I can't do more than that because each doctor has to play, because we need to do 5 cases every hour for us to get to 150 cases. So only 5 doctors, it'll be 90 minutes. It's 12 weeks duration. So we do all of the OSCE things, and it'll be $1,500. The other one that I have is one-to-one coaching. That is one-to-one, and I have from February to now, I've only had 2 students who fail. The rest of them have passed, and the second student passed again. Anything else? Okay, this is the website. So my website is OIMED, and inquire@oimed.com is the email that you can contact me. This is my phone number. And if you were in my Telegram and you got kicked out of the Telegram, I didn't do it. Telegram upgraded itself to some super group. I have no idea what it is. And from 186 members, it is now 120. So you will have to join again. I'm sorry, I didn't do it. Any other question? Anything else you would like to know?
So, Doc, for 12 weeks course, you are going to do like a morning to evening session, or you have any particular time?
I am preferring to do in the evening, so 7:30 to whatever time that evening suitable for people would be the one that I'm happy with.
Okay.
But if there are doctors there are 5 of you who wants to do in the morning, we'll see if I can work around that.
Okay,
Remember,
Doc.
I'm based in Brisbane, so the time is always important.
Yeah. Thanks a lot for this
You're
session.
welcome. And any other questions with the OSCE? Do you have any questions or anything that I can help you with? No? That's okay. Thank you for joining this session. I hope this session was beneficial to you, and good luck. You can do this. If I can pass this OSCE, anyone can. I'm
Thank
not
you.
the brightest spark. Anyone can.
Brightest people always says that.
Enjoy your day, and thank you. Goodbye.
Bye, Doc.
Bye. Have I looked at all the comments? Okay, I will stop this. Stop. Where's my stop button? Oops. Need to stop share. And so, and